Good afternoon, everyone, and welcome to today's program on hereditary neuropathy and genetic testing. I'm thrilled to have two special guests today talk about hereditary neuropathies and the benefits of genetic testing. During this webinar, we will address the problem of misdiagnoses and the benefits of getting genetic testing early on to lead patients down the right path for treatment. This program will also address the value of genetic counseling for families that are impacted by hereditary diseases. My name is Lindsay Colbert. I am the Executive Director at the Foundation for Peripheral Neuropathy. And again, I'm so very pleased that each of you have joined us today to learn more about this topic. Before we get started, just a few housekeeping issues. I wanted to let everyone know that this presentation is being recorded and the recording link will be emailed to you so you can view it again later and also uploaded to our website. Please submit any questions you have via the questions box and we will try our best to answer them during the end of our webinar. And at any point, if you're having trouble with the audio, please feel free to dial in by phone. The email that you received to dial in for this presentation is also the same email that includes the phone dial-in instructions. At this time, I'm pleased to introduce both of our special guests today. Dr. Sami L is joining with us with more than 20 years of experience in diagnosing and treating patients with a variety of neurologic diseases, and he's an attending neurologist at Penn Presbyterian Medical Center. He co-founded the Penn Amyloidosis Center, one of the largest multidisciplinary programs in the United States, treating patients with hereditary and acquired amyloidosis. They are a group that is active in clinical trials and cutting-edge therapies for this group of diseases. Dr. Khella's other interests include treating patients with acquired inflammatory neuropathies, such as chronic inflammatory demyelinating polyneuropathy, also known as CIDP, and other myopathies. Also joining us today is Shawna Feely. Shawna Feely is a certified genetic counselor specializing in neurology. She works with people who have a family history of neurological disorders, especially Huntington's disease, a progressive and incurable brain disorder. She sees as many as 15 patients a day at the University of Iowa hospitals and clinics, guiding them through all phases of genetic testing. Thank you again, both of you, for joining us today. And at this time, I'm pleased to welcome Dr. Khella onto the screen so he can begin his presentation. Thank you again.
Thank you so much, Lindsay, and your team for inviting me to this really special program. It's always a delight to talk and educate people about amyloidosis, disease that I've treated for a very long time. And I'm excited to see patients with amyloid because we have a lot to offer. So I'm going to talk for about 15 minutes or so and go through exactly what is amyloid neuropathy, and some of the therapies that are currently available. It's always difficult, I'll just say right now, to answer specific patient questions about their own particular problem. And I, not to be rude, but I always like to defer to the healthcare provider that is seeing you in particular. So amyloid, the word amyloid means you have a protein in the body that is misfolding, and when it misfolds, it doesn't work properly. And it becomes what we call a toxic protein, or a protein that is now damaging to different tissues or organ systems. And so there are many things that, many diseases that in which amyloid proteins are involved. Alzheimer's disease, for example. The diseases that we're talking about today do not typically affect the brain, so they don't cause an Alzheimer-like picture, but rather they cause nerve problems. And so what is a nerve, and what are nerve problems? Nerves are the wires of the body, if you will. and they are the wires that connect the impulses that are coming from the brain and the spinal cord to the muscles to make the muscles move, to the skin to help feel. So they bring information from the skin, from the feet, from the hands, back up to the brain. And the brain then interprets what the nerves, the electrical signals that the nerves have passed onto it. And so when people have a peripheral neuropathy from whatever cause, not just amyloid, I mean, the most common ones in the United States today are nerve problems caused, or neuropathies as we call them, from diabetes, for example. There are many other causes of neuropathy. If you drink too much alcohol for a very long time, you can get a neuropathy. If you have take some medications like chemotherapy drugs or other drugs, you can get a neuropathy. So neuropathies, by and large, cause a combination of numbness, tingling, and weakness, some combination like that. Now, you have to remember that even though I said amyloid doesn't cause brain problems, there are many other problems in the brain from other diseases like MS or strokes that cause numbness and tingling and weakness. So it's up to your doctor, primarily the neurologist or the nurse practitioner, to figure out if the numbness and tingling that a person has is due to a brain problem or a nerve problem, or what we call localizing the problem, localizing the origin of the numbness, tingling, or pain. Neuropathies, and especially neuropathies that are caused by amyloidosis, cause both numbness, tingling, and weakness. This is in contrast to diabetic neuropathy, which some people in the audience may also have. And diabetic neuropathy typically doesn't cause a lot of weakness, unlike amyloid neuropathy. So people who have diabetes and have amyloidosis, sometimes it's hard to sort out which is causing the problem. Is it the diabetes, or is it the amyloid, or is it both? And why it becomes important to figure out what the cause of the neuropathy is because there are special treatments that can be given. The neuropathy from amyloid, and let me just talk about that for a second, is a process that is typically rather slow going, but not very slow. So slow going meaning it takes, it proceeds over months to years rather than minutes to days or weeks. So some neuropathies that move very quickly like that are like Guillain-Barré syndrome, for example, or chronic inflammatory demyelinating polyneuropathy. That's a mouthful. But so CIDP, so-called. So those neuropathies progress fairly quickly over weeks to months rather than months to years, the way you see in amyloid. But and amyloid can be tricky to diagnose. The reason is that the neuropathy, when it starts in amyloidosis, it looks like any other neuropathy. So it looks like the very common ones, like I said, neuropathy from diabetes, neuropathy from alcohol use. People over the age of 60, about 10% of them will develop a neuropathy just by virtue of aging alone. So it's and all of those neuropathies, they look the same in the beginning. And so there's a little bit of numbness, a little bit of tingling. It typically begins in the feet. There may be carpal tunnel syndrome associated with it. And so numbness, tingling in the feet. And then if you have that numbness and tingling in the first 3 fingers of either hand, which waken you up from sleep at night, that's typical of carpal tunnel. And people with amyloid can also get the carpal tunnel, but people with diabetes can also get carpal tunnel and a peripheral neuropathy. And the distinction and the difference is that over time, so over months or even a year or a couple of years, people with amyloid will typically get weaker in that they have trouble with the muscles up here, what we call the proximal muscles, the muscles closest to the body, as opposed to the hands, which are the distal muscles. So people who have proximal muscle weakness in amyloid, people with diabetes typically don't get that. And also people with amyloid will have trouble getting up from a chair because the thighs are weak, the thigh muscles, the buttock muscles are weak. And so they have trouble getting up out of a chair, getting up off the toilet seat, getting up and down steps. What we call proximal weakness, or weakness in the muscles closest to the body, as opposed to the feet or the hands, are typical features of amyloid, but they're not typical features of diabetes. But like I said, these may take a while to develop and show up. So if you have a peripheral neuropathy and that is not really changing over many, many years, it's very unlikely that it's from diabetes. On the other hand, if you have a neuropathy that is changing over months or even a couple of years and becoming worse, then you know that that's not typical of diabetes, and you have to look for other things, and among them is amyloid. People with amyloid also have other organs, because this is, like I said, a protein that becomes abnormal, and that protein may get into the heart tissue, and so they may get what we call a heart failure or a cardiomyopathy. Again, very important to figure that out because that is treated in a particular way by certain specialists, and it can be an emergency because even though I told you that amyloidosis and amyloid neuropathy typically develops over a long time, there are some forms of amyloid that I'll get to in a minute that are more or less a medical emergency. But just to continue with the different organs that are affected, the amyloid protein, the abnormal protein, can develop in many organs of the body. Heart failure is one of them. The stomach and the bowel is another, and that can cause diarrhea and constipation, or alternating diarrhea and constipation. People with amyloid also have what's called lightheadedness or orthostatic hypotension, meaning they stand up rapidly and the blood vessels don't work properly, and so patients become lightheaded and need to sit down or can't stand up for a very long time. Other organs that are affected are rarer. The eyes can become affected. The lumbar spine can give symptoms that are akin to spinal stenosis, can become affected. Anyway, the different kinds of amyloid that cause the symptoms that I just described are either inherited or what we call acquired. So when amyloid is inherited, and Shawna is going to tell you a lot more about that, you can do what's called genetic testing and figure out what gene is abnormal. You need to be sure that the amyloid that is found in a body part is not due to what we call light chain disease. So amyloid light chain is different from hereditary amyloidosis. Hereditary amyloidosis, when you do the genetic testing, you will find a genetic abnormality or variant that Shawna will describe. When you see your neurologist or cardiologist, they will do a test for what's called light chain disease. So amyloid light chain is made by a group of cells that are behaving like a malignancy and need to be treated by an oncologist or a hematologist. So light chain disease, like hereditary disease, like what we call wild type disease, and wild type is a third type of amyloid. So we have hereditary, we have light chain disease, we have wild type disease. And wild type, there are no genetic abnormalities and there is no cancer underlying it. And it typically causes just the heart to become a failing organ or develop heart failure. I've said a lot now so far. So this is sort of a whirlwind tour of amyloid. Let me just briefly touch on the therapies. So the therapies that the neurologist and the cardiologist primarily treat are hereditary amyloidosis. And like I said, hereditary amyloidosis, there may or may not be a family history, so it doesn't always have a family history as part of the patient's background, but you can do the genetic testing and you find the one protein called TTR or transthyretin. Now that protein, that's what it becomes amyloidogenic, is a malformed protein, and it becomes the protein that sits in the nerves or sits in the heart and causes the failure of those organs. We have learned that by lowering the amount of that protein that gets secreted into the bloodstream, so the protein is made in the liver, and then it's secreted or pushed into the circulation, and it circulates around the bloodstream and goes to different parts, and it carries some hormones and stuff. But the point is that if you lower the amount that the liver is making, you're lowering the amount of toxic protein in the heart and in the nerves. And so you lessen the damage that's happening to those organs. And that's how we're treating this disease now. So it's very important to get a timely diagnosis, because the sooner you make the diagnosis, the less organ damage there is, and you can prevent. We have shown now, many studies have shown that the sooner you get treatment for this disease, the less organ injury there is, and the better off you're likely to be. So this is sort of a word not only to a patient who has hereditary amyloidosis, but it's also a word of advice to the family members, because when you get tested in a timely way, and that doesn't, now hereditary amyloidosis doesn't show up till people are typically in their late 40s, early 50s, or 60s, or 70s. So you don't want to be testing people who are in their teens or 20s, as I'm sure Shawna will touch on. But later on in life, in middle age or later, it's a good idea to get tested, because then you can get connected to an amyloid expert in the area where you live, and they can keep an eye on things and hopefully prevent serious injury and improve a patient's life. And so, Lindsay, this is all I'm going to say right now, and we'll be happy to carry on and answer questions later. Thank you.
Sounds great, Dr. Khella. Thank you so much. And as he just suggested, we will be taking questions later on. But before we do, I'd like to invite Shawna to come back onto the screen so she can present her presentation as well. Shawna, thank you so much again.
Sure, thank you for inviting me. So I just wanted to go do a brief overview in general of hereditary neuropathies. We have a big multidisciplinary hereditary neuropathy clinic here, where we specialize in a variety of different types of genetic diseases that cause problem with the peripheral nerves. So we heard about a lot of different types of peripheral neuropathy, which is a problem with those long nerves that go out from the spinal cord to the hands and feet. And this is specifically about hereditary forms of peripheral neuropathy. So these are some of the questions I'll just be reviewing. What is hereditary peripheral neuropathy? What are different forms? Genetic testing, what is it? And why do people get it? And genetic counseling. So as I mentioned, peripheral neuropathy is a problem with the long nerves that leave the spinal cord and go out to the hands and feet. And we heard a lot of different types of peripheral neuropathy, but what sets different types of hereditary forms apart is there is a gene change that's leading to those symptoms. And we can test and determine what type of genetic problem is leading to the damage to the peripheral nerves. It is a mouthful, but they refer to these as peripheral nerves because they are in the periphery of the body, and affecting the nerve cells as opposed to things like directly muscle cells or those types of things, which are myopathies. So in neurology, we try to sort of localize where the problem is coming from originally. And in the peripheral nerves, that can localize to what we call the myelin, which is the outside part of the peripheral nerve, or it can localize to the axon, which is the center part of that nerve. And you can kind of think of it as an electrical wire, where the myelin would be sort of the rubber part of that nerve, and the metal part would be like the axon, the center part of that nerve. So there's kind of two components, and you may do things like an EMG or nerve conduction studies to measure different parts of the peripheral nerve in order to localize where the problem is coming from. But in general, there can be a variety of different symptoms, such as sensory symptoms, loss of sensation, or pain symptoms that can come from peripheral neuropathies. They can also cause, hereditary neuropathies can cause things like muscle weakness, or loss of the ability to detect where your body is in space, so proprioception. People can have kind of changes to their gait, or they may have problems with hand function, or changes in foot structure, that sort of thing. When we look at general subtypes of neuropathies, there's kind of huge groups that we look at. Amyloidosis is one of those. There's also conditions housed under the Charcot-Marie-Tooth disease umbrella. Even in these subsets, like for CMT or Charcot-Marie-Tooth disease, there's over 100 different genetic forms of CMT. So you can see that this is quite a diverse group of conditions, and it's not always simple to be able to determine what the genetic cause is or how it's being passed on in the family, and that's where genetic counselors can help. So genetic testing, medical genetic testing, is a little bit different than some of the tests that are available, what we call direct-to-consumer testing, which you can order a kit and send away to look at ancestry or these types of things. Medical genetic testing, typically it involves a blood test, or we might do a saliva test. And it's usually ordered by a provider or a genetic counselor or someone in a medical institution or a place. And it's linked to a specific medical condition that either that individual has, or if they have a family history and we're trying to identify the genetic cause for that condition. This is a type of specialty testing that again goes through a ordering provider and usually to a specialty lab that is approved to do that type of testing. And it can be complex to know which lab to use. Like I said, there's many different genes associated with these conditions, and there might be varying costs associated with it. So genetic counselors help people to navigate those. This is an old map, but it's just a map of even some of the genes that had been identified. This is in 2015 for genetic neuropathies, and there's even more now. Our group does a lot of gene discovery as part of this process, because there's types of inherited neuropathies that people, we haven't identified the genetic cause yet. So even in the last year, we've helped identify 5 new genetic causes of hereditary neuropathy. So you can see that this list of genes is ever expanding. So hereditary neuropathy is not one disease, even though the symptoms can be fairly similar one to another. It is actually really a lot of different diseases housed under this umbrella. There's hundreds of genetic causes for neuropathy, and the symptoms can be highly variable in terms of age of onset, in terms of severity of disease, and how it's passed on in a family, or what we call the pattern of inheritance. Even just today, and being in clinic, I had a gentleman that was asking, well, is this really genetic? My symptoms didn't start till I was in my 60s, and the answer is yes, it can still be genetic even if it didn't start in childhood. So it really just depends on the genetic cause and what it takes to get to the point where someone might experience symptoms. So because of that, genetic testing can be complicated, and working with your local provider can help, or working with a genetic counselor can help you navigate that process. These are just a smattering of some of the genetic testing labs that offer neuropathy panels at this time. They're not all the same in terms of what's offered on those panels, like in terms of the number of genes or which genes. They vary in cost, and they change all the time. So again, it's a complicated process to get to that diagnosis. And I just want to touch on what we mean when we say genetic testing, and what that process looks like in a medical context. So when we are looking at genetic testing, oftentimes now genetic testing is offered in a panel type of process, where you're looking at a collection of genes that have all been linked to a certain disease, like hereditary neuropathy. And so you might order a panel with, for example, 100 genes on it. What they're looking for is the genetic testing process means that you're looking at specific genes that are localized on a variety of different chromosomes. So a gene is sort of the instruction manual, or like the recipe for a particular protein that functions in our body. So we have many different genes on each chromosome. The chromosome is sort of like the housing structure, or the bookshelf where these instruction manuals are kept. And when you look up at a gene up close, it's represented by a string of letters, a very simple sort of genetic alphabet that uses 4 letters, A, C, T, and G, and those are strung together on 3-letter genetic words that spell out to the cell what it needs to make and how it needs to make that. So these 3-letter genetic words each code for a specific amino acid, and those amino acids are strung together like beads on a string that make the proteins that function in our body. So that's kind of a basic bio 101, going back to school, of our genetic information. So when we are doing genetic testing, we are looking at sort of the spelling to see, is there a spelling change that may lead to a different amino acid being created, and that could cause an abnormal protein, something that's not functioning like it should be. So we're actually looking at the spelling and the number, the letters, and if they're the correct letters, there's the correct spelling, in order to see if this is functioning or not. There's other things that you can also look for in terms of if there are problems where there are missing letters, deletions, like deleted part of the gene, then you might have a non-functional protein because something is missing as part of that protein, or there can be insertions and different things like that. But that's the premise of genetic testing, is sort of looking at that code and seeing, is this instruction manual correct, or are there changes that are there that should not be there? So a lot of times people haven't encountered a genetic counselor, and I just want to touch on what our role is in the healthcare system. We are genetic counselors help people understand and adapt to the medical and psychological and familial implications of genetic disease. And my specialty in neurology means that I work with folks with hereditary neuropathies, or even also central nervous system conditions that are genetic, that affect the nervous system. And you can find a local genetic counselor on the National Society of Genetic Counselors website, which I indicated there. So we help patients or families, we help guide them through the testing process to pick an appropriate lab, to be able to get an appropriate test, which may allow them to have answers about what's going on in their medical health. We help to facilitate the most cost-effective approach to testing, because genetic testing has really dramatically come down in cost, but it can be challenging to know what the appropriate test is and how much it's going to be. So we navigate that for patients. We try to allow patients to get the test that will yield the most likely positive test result, giving them answers. As I mentioned, not everyone who has genetic testing can find the genetic cause to their symptoms, and that's because we don't know all the genetic causes of disease yet. In many specialties, but in particular for hereditary neuropathies. And we also go through the pros and cons of testing for patients in terms of making an informed choice and whether testing is appropriate for them. So some of the reasons people do genetic testing is to determine if other family members are at risk, for family planning options. So it may not just be for treatment, but if you identify a genetic cause of a disease in the family, then you know who's at risk. And in some cases, you can then use that information to prevent passing that genetic disease on to future generations. These are some of the family planning options that, excuse me, genetic counselors might discuss, including testing during or before pregnancy, or other options for people to build families if they want to prevent passing a genetic disease on. Other reasons is just having a definitive diagnosis. People live for years with, these conditions that can progress over time, and people a lot of times just want a name for what's going on, and that gives them an understanding of what they have, a name to describe it, and maybe resources in a community where they can reach out to. And then, of course, possible access to treatments or clinical trials. So this is a rapidly changing environment in terms of hereditary neuropathies, and there's clinical trials coming around the bend. We've heard just recently related to transthyretin treatments for that particular gene that causes neuropathy associated with amyloidosis. So these treatments are, coming available or in clinical trials, and currently, it's really important to have a known genetic cause so you're eligible for those types of treatments. So we were talking earlier about gene silencing, and that's an approach for potentially for some of the treatments for these types of conditions, particularly for transthyretin-related amyloidosis, where, when going back to that analogy, when you are looking at our genetic code, or it's kind of like a recipe or a blueprint, and the cells use that information to then create the protein, or in this case, just using this analogy, the cake. And you need to have the correct recipe in order to produce the protein that functions in the body. And if there's changes in that recipe, there will be changes in the way that protein potentially functions in the body. But you need an entity to help with this process to create that cake. You have the recipe, and you need sort of a chef in some ways to create the protein or the cake. And gene silencing sort of takes the chef out of the picture, so that even though people still have their same genetic code, it's not being created into any sort of protein, and therefore can block whatever that abnormal or toxic protein was doing, because it's no longer being created in the body anymore. So that's just kind of an example of one of the types of gene therapies that we use to potentially treat more and more of these diseases. Some people decide that genetic testing is not for them. For example, there may be a risk of inconclusive results or not really giving an answer for them, and what do they do then? They still kind of at the end of the day are in the same situation where they don't really know what's causing their symptoms. There can be an emotional impact on the family system, positive or negative, from positive or negative results. And a lot of these diseases, because they're genetic, affect other people in they might people might feel guilt about passing on a genetic disease, things like that. So this goes into some of that decision making. Genetic testing is not available for everyone. We don't know all the genetic causes, and then there's complicated additional tests that might be done, such as research-based genetic testing. Sometimes people have concerns about genetic discrimination, so genetic counselors talk about what genetic discrimination is and ways to protect yourselves, things like that. And then, like I mentioned before, there's varying degrees of cost associated with this, and that often is a big question that people have, is what's this going to cost me? And so genetic counselors help to navigate that. And there's other issues that we discuss. For example, a lot of these, I'm sorry about that, my local phone here. A lot of these end up, being genetic diseases that people could potentially pass on to their children. And so at what age do you offer genetic testing, and how is that offered? Usually we're not testing minor children for adult onset conditions. So we would talk about genetic testing options when people are over the age of 18. So in summary, there's many different types of hereditary neuropathy, and genetic testing can be informative for family members and for individuals. So that's why a lot of times people decide to work with a genetic counselor or their physician to do testing. In general, genetic testing can be complex, so we encourage people to seek out genetic counseling to help make that decision. And in many cases, or in some cases right now, it can lead to treatments or clinical trials, but we expect that to be increasing in the future. And I'm just gonna end there, and then we can go back to the group for questions.
Thank you so much, Shawna. I'm going to pop on as well, just to say thank you again to both of our presenters. We've had quite a slew of questions that have come in over the course of this presentation. So I'm going to go ahead and turn it over to both of you for some of these questions. If you're comfortable coming back on screen, feel free to. Otherwise, I'll just stay on screen and ask them accordingly. So one question is, how are new variants discovered? So obviously some people have had extensive genetic tests done and none of the known variants have shown up. So how are new variants discovered, and how are those unknowns soon to become known variants?
So Shawna, you want to take that?
Sure. So kind of thinking of variants is are changes within a gene. So we can identify new variants or new changes within a gene, but there's also gene discovery that occurs as well, and that's looking at genes in general and what is associated with a particular disease. And so there's kind of two processes we're talking about here, two levels, I guess. So we are actively doing gene discovery, and that is where, say there's over 100 different types of hereditary neuropathy. However, when we know someone has a form of hereditary neuropathy, we cannot always find their genetic cause. And so we enroll people in research studies where their de-identified genetic data is housed in a platform where we can look at that data and compare it to other families with unknown hereditary neuropathies. And if we identify a change in a gene that is consistent across that group of people, then that is potentially a new gene that's identified as causing a new form of hereditary neuropathy. So we've recently, like I said, just in the last year, discovered 5 new genes. 2 years ago, we discovered a new gene called SORD, and that's now in clinical trials. So gene discovery then can feed into clinical trials where people can have access to treatment. So gene discovery is a really important process to be able to kind of figure out the what's broke part, so you can try to figure out a way to know how to fix it. Variant changes occur all the time in medicine. We're constantly offering genetic testing to people, and you can find a change, which we call a variant, that may or may not be linked to a particular disease. Even in genes that we know cause hereditary neuropathy, new variants are found all the time. And so we encourage providers working with patients to report variants, because it's really important for the future of our knowledge of these genes. So even in genes like TTR, which we've talked about, or CMT genes, there can be changes, and we don't know if they actually cause disease or if they're just a benign change that can be found in the population. And so reporting those variants are really important for the future of patients in these diseases, so we can interpret what they mean. And there may be people in the audience who've had genetic testing and they get reports back that say variant of uncertain significance, and that's exactly what that is a change, and we don't know, we can't interpret it, we don't know if it's connected to a person's disease or not. And so that's where putting those reports out there in the public can help us understand.
And is there any one genetic test that covers the most common inherited types of neuropathies specifically that you know of, Shawna?
There are many panels for hereditary neuropathy. I kind of showed a slide of a smattering of labs across the United States that are all do hereditary neuropathy testing. And so they can be, anywhere from 20 to 40 genes, upwards of hundreds of genes. And so really it's getting an evaluation, localizing maybe where the problem might be starting in the nerve, and letting that guide your providers to what test would be appropriate for you to be able to get the most likely answer.
Okay. Dr. Khella, so if a person's tested and found to have amyloidosis and they're successfully treated to stop further damage, is the previous damage, are those tissues ever able to heal, or is it kind of non-reversible?
Right. So it really depends on how damaged those tissues are. Tissues typically can heal. It also depends on what other medical conditions a patient has. So if a patient has diabetes, for example, and already has a neuropathy from diabetes and has then developed a second problem like amyloidosis, it may not heal as well. So it both depends on how advanced they are and what we call comorbidities or other illnesses.
Sure. And are there specific blood tests that people should do to learn more about either their likelihood or of getting amyloidosis or having amyloidosis? Is there specific tests or specific blood tests that you guys know about?
Well, so like many things in medicine, it's not one test that makes a diagnosis. You need to have, even if you have an abnormal gene, or let me put it this way, a gene that's connected to a known amyloid condition, like the V30M gene or the V122I gene or any of those other genes, that doesn't necessarily mean you have amyloidosis. You can just be a genetic carrier. So you have the gene, but you don't have the disease itself. Okay. And so there is no one test that we do to make the diagnosis. And a diagnosis of amyloid is really made by tissue biopsy rather than a blood test per se. So really, I think if there's a concern about amyloid, you really need to talk to an amyloid specialist.
And, you know, Shawna, and you just referenced this, Dr. Khella, but what's the risk of passing inherited neuropathies onto children? Should patients be concerned about that, and to what extent?
Because there's many different types of inherited neuropathy, there's many different ways that it can be passed on in a family. So gene identification or identifying the genetic cause helps us to know who else might be at risk in the family. And that's one reason people do genetic testing. So one way, for example, if a particular gene is associated with autosomal dominant inheritance, in that case, the gender of the parent or the child doesn't matter. There is a 50% or 1 in 2 chance of passing that genetic disease on to each child. But if it's recessive, meaning that, again, gender doesn't matter in that case, but in recessive inheritance, both parents have to be carriers of a genetic disease in order for a child to be affected. So in that case, the child, it's a close to 0% chance that a child would be affected. So those are pretty big differences, up, 50% to 0%. And so knowing the genetic cause would allow us to give a more accurate risk for assessments for children of someone who's affected. And that's another reason why people might want to do testing.
Are there any recent advancements in testing or other just treatment modalities generally with inherited neuropathies, such as CMT or CIDP? Is there anything kind of that either of you would want to highlight for things that are coming out soon or just recently came out?
So first of all, just a small clarification. CIDP is not an inherited neuropathy. It's what we call an autoimmune neuropathy. So your immune system gets confused and starts to attack your own nerves. There are always new therapies and new modalities of treating people with peripheral neuropathies. And this is a plug for people to get involved in clinical trials. And this is how we figure out new treatment modalities and ones that are not even available on a commercial basis, so that you can't get it because your insurance company won't cover this kind of thing. And it's just, I just want to be clear that this is not, being in a clinical trial doesn't mean you're a guinea pig. And that's really important, because it's not something that we're just testing on you. I think these trials are done in a very thoughtful way. The ethics of a trial are considered. If there are available therapies, you're not denied those therapies. So I just want people to understand that in being involved in a clinical trial is really a way to advance science and to advance the treatment for everybody, and hopefully to advance the treatment for the patient themselves.
And our organization has a list of various clinical trials that we highlight that are focused on peripheral neuropathy. So I just want to highlight that for those that are watching today. But do either of you have any other suggestions on identifying a clinical trial that is appropriate and something that would be helpful for the advancement of finding more answers?
There are trials that are listed on clinicaltrials.gov is a great website to look up. You can just put in your kind of disease of interest or condition of interest, and it'll pull up different clinical trials that are being offered. Some of those are what we call natural history studies. So those are understanding how a particular condition progresses over time. So you're not really, those are not interventional trials where you're getting a medication or intervention, but they are still very important because that's how we design interventional trials, is knowing how the disease typically progresses and developing outcome measures to be able to measure disease over time, and then being able to use that knowledge in an interventional trial to see if you're slowing a particular condition down or stopping the disease based on your knowledge of that condition. There are, as we identify more and more genetic causes of neuropathy, those are going to be progressing into the clinical trial space. Right now, one of the most common forms of CMT, CMT1A, is going to be entering into human trial space soon. It's already gone through many levels of like animal studies and things like that. So these are very exciting, and we hope that as these become more and more available, that these, as if they work, that these treatments are then going to be models for treating other types of inherited neuropathies, so that you can kind of use the same techniques to bring more even rare forms of inherited neuropathy into the clinical trial space and into treatments.
And a lot of these inherited neuropathies like CMT2N, it's so rare that patients are actually not even able to find a clinical trial. Are there clinical trials for every form? I know that's kind of an impossible question to answer because it depends on when and where people are searching, but for the rare neuropathies that people are wanting to participate with a clinical trial on, what's then the next step if they can't find something and they still want to get involved a different way? Or isn't there?
I would say kind of broadening your search. So instead of saying CMT2N, look for trials related to CMT, because then you're going to find the researchers that are interested in CMT in a broad sense, including those more rare forms of inherited neuropathies. So looking at organizations, support organizations that include all forms of neuropathy, just not specific types, or looking for clinical trials like on clinicaltrials.gov website that specifically deal with the broader sense of that disease. We do a lot with CMT in general, and we enroll people with any form of CMT, including unknown forms of CMT. So even if someone has not been genetically defined, so those are, there are researchers that are, you don't have to be so specific, I guess.
And is pain a common symptom of amyloidosis specifically, Dr. Khella? Do you know if that's a common symptom, or is that something that might be associated with a different form of neuropathy instead?
No, pain is a common symptom, but it's not a necessary symptom. So not everybody who has amyloid neuropathy has pain. They may just have numbness and tingling. Like not everybody with diabetic neuropathy has pain. And then other forms of neuropathy, even inherited neuropathies, can be painful or painless, so it's really very variable.
And the last question that I kind of want to throw at both of you before we close out today's session is, a lot of our patients are frustrated. We know a lot about the causes, but we don't know enough about the solutions. And I'm curious if either of you could just speak to that with respect to what, as I said, you might know would be coming, or thoughts of hope for our patients so that they know that we are here trying to figure stuff out.
So it is, medicine is always advancing, and there are always new things on the horizon. I think the best approach is to establish a good relationship with somebody who's an expert in the area of your disease, and be in touch with that person once a year, once every couple of years, once every 6 months, depends. Because there are always new things that pop up, and they may pop up from time to time, and unfortunately that you may not be right on that on your doctor's radar. So that's why it's always good to just check in, even if you don't have anything that's immediately treatable. And it is frustrating, and I get that.
Thank you.
I think from my perspective as a genetic counselor, my style of counseling has really dramatically changed because, you know, there was a time when we would say, and this is what you have, this is the genetic disease, and right now there's nothing right now we can do about it. But now there are, you know, there are treatments that are becoming available or going into the clinical trial space. And so counseling and talking with patients, we say, this is what the disease is, and these are the ways that there are either ways to potentially treat this disease, or, you know, so you're kind of changing the way you provide information to patients because things have changed so dramatically, I would say, even in the last 10 years. And we have a real, you know, optimism about the future of treating these diseases. You know, TTR related neuropathy is one of those success stories, but I think that there's going to be many more on the horizon. So I would also say that this research happens not in a silo, but as a partnership with people. So people who are living with these diseases, partnering with researchers and research teams to be able to help move things forward and allow us to help develop outcome measures or develop ways of measuring things that are important to the patient and not just something that a physician can measure. Like, we use things like a tuning fork to measure sensation, but does that really matter whether someone can feel a tuning fork on a day-to-day basis? No. So we need measurements of symptoms that really profoundly impact a day-to-day life for people. And so it's only with partnering with patient advocacy groups and patients living with the disease that we can move these forward. And I've just been really, you know, part of my job, 50% of my job is involved in research and helping with these trials. And it's just been amazing to partner with families and individuals affected by these diseases through my career, because they're very dedicated people out there wanting to help us all move this forward to cures.
I agree, and I second that. I think that's also a great way to kind of conclude this session, because as a patient advocacy group, we also rely so much on you and fellow experts on advancing more answers. And so thank you both again. I also want to thank Alnylam for sponsoring this extremely fascinating and informative webinar. As I mentioned, this will be housed on the Foundation for Peripheral Neuropathies website for the foreseeable future. So we hope that many more people will be able to learn about this and, you know, do more follow-ups in the future. So thank you again, everyone, for joining the session. There will be a survey at the end. We hope that you take it. This is our opportunity to continually know what our patient population is looking for more answers. We hope you'll continue to support us so that we can continue to do these kinds of programs. And again, Dr. Khella, Shawna, thank you both so very much for your expertise today. We're so very thankful, and have a good rest of your day, everyone, and keep in touch. Thank you again.
Thank you very much.